Great. Welcome everyone to our keynote session. So we're just going to do what we always do. We're just going to give everyone 5 minutes to join so they can make sure that they're set up, because we know that we're all adapting and getting used to using Zoom. But for those of you who have joined us, we've got Sarah Cassidy and Jacqui Rogers coming up to deliver their keynote talks. So let's just start just under 5 minutes. Hello everyone, thank you very much for joining us. This is our final keynote session with Sarah Cassidy and Jacqui Rogers. We're just giving everyone a little bit of time to join us on Zoom, so we'll be just starting in just under 2 minutes. Hi everyone, thanks for joining us. We're just going to start in a minute. I'm just going to give everyone 1 more minute to join us before we get started. Great, so I think I've given everyone a good chance to get logged in and to join us online. So we'll make a start now. So welcome to our final keynote session. We've got 2 fantastic speakers coming up now. I'm just going to start with a few formalities and introductions as well. So if you're using social media online, do use the hashtag Autistica Festival as a way to communicate. If you have any questions for our speakers, do use the Q&A function to share questions with speakers and to remind them. You know, so these will happen, and then we'll basically what we'll do is we'll answer them at the end of each talk. Please be nice and respectful. We always say at this conference, you'll hear some things you agree with and some things you don't. but you just try and maintain that respect and be kind with people as you share your opinions and ask your questions. So just to let you know, these presentations will be recorded, and we will be sharing them after. So don't worry if you miss anything. We're very happy to make these talks available at a later stage. So I'll now just get on to introducing our first speaker. So we're really excited to say our first speaker is Dr. Sarah Cassidy. Sarah is an assistant professor at the University of Nottingham. She spent 2 years as a postdoctoral researcher at the Autism Research Centre in Cambridge before starting her own research group at Coventry University. Sarah has been just a massively important and impactful, multi-award-winning researcher and advocate for understanding and preventing suicide in autistic people. And one of the things that she's really well known is the way that she undertakes her work in partnership with autistic people as well. And that's what today's talk from Sarah is all about. So I'll now hand you over to Sarah, who will share her talk, and I will disappear. There we go. Thanks, Sarah. So
thank you so much. Thank you so much for inviting me to give a keynote talk. As part of this wonderful festival, I'm really excited to share our progress on this really underexplored topic with you all. Before I start, I just want to let you know that I'm going to be talking about some tricky topics. I'm going to be talking about understanding and preventing suicide in partnership with autistic people. So I'm going to be talking about why autistic people might think about, attempt, and even die by suicide. So if this isn't something that you want to hear about right now, then please feel free to pause the recording, because it's going to be recorded. You're not going to miss out on anything. And if it becomes too much as you're listening to the recording, then please feel free to unplug, because it's going to be recorded and you're not going to miss anything. And also in the chat function, Autistica staff have helpfully put in a link to support. If you need further support, or if you need to talk to somebody, then please check out that page, and I'll signpost people to that page at the end of this presentation as well. So a lot of people ask me, how did I get into researching suicidality in autistic people? And it happened in 2014 when I published a study during my postdoc at the University of Cambridge. And I analysed some clinic data over a 9-year period from the Cambridge Lifetime Asperger's Syndrome Service, which is a specialist service for late diagnosis of Asperger's syndrome in adulthood. And in a cohort of adults who've been newly diagnosed with Asperger's syndrome, on average at about 34 years old, so very late in life, very delayed, we asked them before they went to their clinical appointment to confirm their diagnosis of Asperger's syndrome, have they ever contemplated suicide? Have they ever planned or attempted suicide? And we found really worryingly high rates. We found that 66% of those newly diagnosed adults with Asperger's syndrome said that they had contemplated suicide at some point, and 35% had planned or attempted suicide. And that 66% of suicidal thoughts in this cohort is significantly higher than the 17% in the general population of the UK. And I did a systematic review alongside this paper, and I was absolutely shocked that there were only 4 small-scale studies looking at suicidality in autistic people. So from that point, I became really committed that I wanted to look more at this. I thought it was really important, and that's what I've been doing ever since. So since that initial study, because it was an early study, It was a clinic study, so it was looking at one population. We didn't use validated measures. There were measures like questions that had just been developed for the purposes of the clinic, which is problematic, and I'll come to that later in my presentation. But since then, there have been large-scale studies. So this is a large-scale population study in Sweden that looked at multiple different causes of early death in autistic and non-autistic people with or without co-occurring intellectual disability. And they found that suicide was one of the leading causes of premature mortality in autistic people. Autistic people overall were twice as likely to die by suicide compared to the general population. Autistic people without co-occurring intellectual disability were more at risk. It was 9 times higher. And the highest group at risk was autistic women without co-occurring intellectual disability, where the relative risk or relative odds of dying by suicide are 13 times higher than non-autistic women. And in a more recent study looking at suicide death in the US, in a large-scale population study there, they found again that autistic people are much more likely to die by suicide compared to the general population. And again, autistic women are the most high-risk group. So there were some initial findings, really important findings, that autistic people are more likely to contemplate, attempt, and even die by suicide. And autistic women without co-occurring intellectual disability appear to be the most high-risk group across these 2 studies. And that's really important because it signals to us that suicide in autistic people might be different than non-autistic people, because in the general population, men are most likely to die by suicide, significantly more likely than women. Whereas in autistic people, it seems to be not so much of a gender difference, and if anything, autistic women are slightly more at risk. I'd also like to mention that all of these studies looked at those with confirmed autism diagnosis, but we know that many autistic adults remain undiagnosed because there's a lack of autism diagnostic services, because a lot of adults have missed out on a diagnosis in childhood, and also there are a lack of validated autism assessment tools for women. Undiagnosed autistic people, we know from a few studies, appear to be overrepresented of those at risk for suicide attempts. There's 2 studies. One looked at a group of depressed patients, and they conducted rigorous assessments to identify undiagnosed people in that group of depressed patients who had undiagnosed autism. And they found that 11% of that cohort of depressed patients qualified, met diagnostic criteria for autism and had never been previously diagnosed. And the same in 15% of patients with borderline personality disorder. And they found that in those patients in both groups, the depressed and borderline personality disorder patient groups, that those who were met diagnostic criteria for autism were significantly more likely to have attempted suicide than those with just depression or only borderline personality disorder. So undiagnosed autism seems to confer increased risk for suicide attempts in already at-risk groups. And in the study that our group recently did, we surveyed a large group of people who had attempted suicide, who didn't have an autism diagnosis and didn't suspect that they might be autistic. And we found that 40.6% self-reported clinically significant levels of autistic traits, which indicates that it would be useful perhaps for them to further explore whether they might be autistic. So undiagnosed autism and high autistic traits are associated with suicide attempts and suicidal thoughts and behaviours. So it's really, really important that in suicide research, we don't just look at those who have a diagnosis, but we also try to identify and make sure that our models work for people with high autistic traits and those who aren't yet diagnosed. So where are we now and what kind of progress have we made? Looking back, I think overall, we've had some really, really important work and a growing number of large-scale counting studies, which have been really instrumental in showing the scale of the problem. But there isn't enough about why this is happening, and we need to know that in order to prevent it and to help people and to prevent these high rates. And there aren't any validated tools or assessments to actually enable researchers and clinicians to identify autistic people or those undiagnosed with high autistic traits who might be experiencing suicidal thoughts and behaviours. And at the beginning, I was just, because there was no research, our first thought was, what should the priorities be? What should we look at first? Because there's just so much to do. And to help with that, I led a 3-year priority setting exercise in partnership with autistic people and those who support them, with the kind support of funding from the Economic and Social Research Council, Autistica, who funded a number of summits that brought together autistic people, researchers, clinicians, charities to discuss the issues. The International Society for Autism Research that gave us 3 years of a special interest group precisely on this topic at the largest autism-specific conference in the world. And also the support of the James Lind Alliance, which is an independent organisation that specialises in identifying and prioritising areas for future research in partnership with those affected, those kind of interested parties, but independent of researchers. So throughout this long exercise that involved all of these focus groups around the world, large online surveys to help prioritise the top 10 and the final meeting, we found these top 10 priorities. So the top one was, what barriers do autistic people experience when seeking help, which put them at greater risk of suicide? And there are quite a few other priorities here that I'll allow you to read. But I've highlighted in bold some of the priorities that I'm going to base my talk around, because all of my, like James said, I think it's so important that all of our research is based on the priorities and the direction of the community. So that's what I'm going to base my talk around. I'm going to talk about what kind of work that we've been doing to try and address these priorities and what there is left to be done. So I'm going to look back at them at the end of my presentation and think, well, what haven't we done and what kind of research do we actually need? So the first aspect that I'm going to talk about is the top priority of the autism community, which is, what barriers do autistic people experience when seeking help, which may put them at greater risk of suicide. So we've done one study on this that was published in 2018, and it was a qualitative study. It's called People Like Me Don't Get Support, which is kind of one of the key themes. And it was autistic adults who gave us qualitative data and self-reported their experiences of getting treatment and support for mental health difficulties, self-injury and suicidality. And I have a picture of the thematic table here that I'm going to talk you through. And they all said that tailored support is beneficial and desirable, and that was something that tied together all of their experiences. But a key theme was that people like me don't get support for mental health difficulties, self-injury or suicidality. They reported being dismissed for treatment or support because they were seen as coping, particularly if they didn't have a co-occurring intellectual disability. They reported that support was geared towards children and not adults. They reported that they had a long waiting list and lack of funding, which made it difficult to access support. When they did manage to access support, they reported a lack of understanding and knowledge on the part of professionals and the services that they accessed. They described obstacles to accessing and treatment and support not being believed or listened to, and the support and treatment that they're receiving not being suited for their needs. For example, CBT, cognitive behavioural therapy, that perhaps wasn't adapted and didn't really work for them. And they reported that this kind of lack of support or appropriate support really affected their well-being. So that if they didn't get support, this had a lot of negative impacts, including increased suicidality, suicidal thoughts, and hopelessness. Whereas if they did get the support that they needed, which some of them did, that was life-saving. It made absolutely all the difference. So it's very, very worrying that a lot of autistic people report that they have real difficulty in accessing appropriate tailored treatment and support for these difficulties. There are also a lot of suggestions for prevention, so useful things that could be changed. They suggested timely access to support, so perhaps having an autistic pathway that was tailored to their needs. They also suggested training developed in partnership with autistic people. Otherwise, if it's delivered by non-autistic people, it can sometimes reinforce unhelpful stereotypes and perhaps not be helpful, even if it's well-intentioned. They also made really, really useful and practical suggestions for things like minor adjustments, like continuity of care. So being able to see the same person and not having to retell your whole history to a different person in every session, having more sessions, because we know from research that it can take longer for autistic and non-autistic people to build rapport, and sometimes just having more therapy sessions can be a real help. Having appropriate sensory environments, so having a quiet space, having natural light, which we know isn't always the case in public surgeries and things with really, really bright fluorescent lighting. They also said that it was really important to have alternative access, so other than having to make an appointment over the phone, such as making an appointment online or using text or web-based support that isn't in person, which we're having to adjust to now, and is showing that a current situation is showing that this is actually possible. And adapted therapies in partnership with autistic people. So I wanted to draw your attention to some ongoing research, or research that is about to start, that's actually moving on to prevention strategies, because I think that this is the most understudied and most important area that was part of our top 10 and is kind of related to this barriers question. And one is looking at how we can adapt readily available tools that autistic people have told us that could have potential and could be useful for the needs of autistic people. And one is safety planning. And this was identified and just spontaneously suggested in a public engagement event talking about prevention strategies. And it's a step-by-step plan in the event of suicidal crisis. And we actually have an adapted draft version of this safety plan publicly available, and you can access it via this link. And we'd be really pleased to hear from people if they find it useful or not. But we also have funding to develop and pilot this adaptive safety plan in partnership with autistic people, so watch this space. And another really exciting and important ongoing study is adapting dialectic behaviour therapy with and for autistic people. And this is shown to be effective in other groups, such as people who are depressed, people with ADHD, borderline personality disorder. We're really excited that perhaps this also could help autistic people. And Anne Hutchins and her colleagues are conducting a project that's looking to adapt this treatment with and for autistic adults. And there's a link to their protocol if you want to find out more about this below. So there are things happening, but this is very underexplored. So another 2 questions in our priority list asked about risk and protective factors, specifically what risk markers may be unique or shared between autistic and non-autistic people, and how applicable are the existing models, suicide models that we have, for explaining why non-autistic people might be more at risk of suicide, and adapting this and seeing how relevant it is to autistic people and how it might have to be adapted. So in our research, when we started looking at these kind of questions, I started working with Mirabelle Pelton, who came and did her master's project with me, and she talked a bit about this in her presentation on Tuesday afternoon. So some of what I'm going to be talking about is going to be talked about by her in a bit more detail, so please check out her talk that was on Tuesday afternoon by Mirabel Pelton. And we were researching different models of suicide theory in the general population and which ones might be useful candidate theories to look at in autistic people. And we came across the interpersonal psychological theory. And in talking to autistic people and their experiences of experiencing suicidal thoughts and behaviours, this model really, really resonated with a lot of the experiences that we were hearing about from autistic people. So in this model, there are three kind of components that need to come together in order for somebody to think about and then go on to perhaps attempt suicide. So thwarted belonging, so feeling like I'm alone and not having kind of meaningful connections to others is one component. Perceived burdensomeness, so perceiving yourself, even if it's not true, to be a burden on others. And capability for suicide, which is experiences of painful and frightening events that allow a person to overcome the fear of death and pain involved in a suicide attempt. So these three things need to come together in order for somebody to attempt suicide. But in order to kind of feel suicidal or think about suicide, these two constructs of thwarted belonging and perceived burdensomeness need to be experienced. And autistic people were describing a lot of things that really resonated with these constructs, such as feeling alone, loneliness, difficulties establishing reciprocal meaningful relationships in the long term, could increase risk of thwarted belongingness, and also being othered by society, not feeling accepted in society, which we know from recent research, and perceived burdensomeness, so things like unemployment, higher experiences of mental ill health, low self-esteem. These things are kind of external indicators of perceived burdensomeness. So across a few studies, we've been looking at how this model could help us understand why autistic people feel suicidal and why they attempt suicide, and what are the gaps. So what aspects of the model don't work. So in Mirabel's first study that she did for her master's, she looked at this in the context of autistic traits in young adults studying for a psychology degree mainly. And she found that people with high autistic traits were more likely to feel thwarted belonging and perceived burdensomeness. And this was associated with suicidality, which is what the theory predicts. But what we also found was that in those with the highest levels of autistic traits, these associations were weaker. And one possibility for that could be that thwarted belonging and depression are, using the tools that we use that have been developed for the general population, don't work or don't capture these experiences strongly in autistic people. So we followed up this study with another study comparing the predictions of this model in autistic to non-autistic people to decide, does this actually work? Is it actually a good model? Does it fit? Does it work for autistic people as well as non-autistic? And we found that overall, the predictions of this model were upheld, but again, the associations were significantly weaker in autistic compared to non-autistic people. So on the left here, at the bottom, for example, you can see that this line here, which is the autistic group, is flattened compared to the not autistic group. And this shows that the association between traumatic life events and lifetime suicidal thoughts and behaviors is weaker in autistic compared to non-autistic people. And the same for thwarted belonging. So these things aren't as predictive of suicidality in autistic people as they are in non-autistic people. So again, we're thinking, do the measures capture autistic people's experiences strongly? And in Mirabel's most recent study, she shows no, this isn't the case. The measures that we're using in these studies, the measures that we're using to capture these experiences, mostly don't work for autistic people as they do for non-autistic. So for example, in these questions, which measure thwarted belongingness, so these days I'm close to other people, these days I often feel like an outsider at social gatherings, these are interpreted and responded to differently in autistic people compared to non-autistic people. And autistic people interpreted all questions on the burdensomeness questionnaire differently to non-autistic people, whereas capability questions were very similar. And that's probably because autistic people have equal difficulty to non-autistic people with some of the negatively worded items. So it shows that perhaps there are different experiences, subtle different experiences in the way autistic people experience belongingness to non-autistic people that we're not capturing with our current measures, and they need to be adapted. And we also need to think about, you know, what aspects of autistic people's experiences that are missing from this model. So alongside this research, we've also been working in partnership with autistic people, as we did in our previous study, to identify difficulties with this questionnaire and gaps in the model. We worked with autistic people with lived experience of mental health, self-injury or suicidality to develop a questionnaire aiming to explore autistic people's experiences of these issues and what kind of risk markers that we were missing that weren't known about before. And we did that using a literature search to identify and propose topics to our steering group. Our steering group then prioritised those topics, and then we co-developed the survey together, and they fed back on a number of iterations to ensure that it was accessible, to ensure that it was appropriate, and to ensure that it covered everything that needed to be covered. And we published this in Molecular Autism, so it's open access like a lot of our other studies. But what we found was that after controlling for a number of known risk markers for suicidal thoughts and behaviours, like being in employment, being satisfied with your living arrangements, having other developmental conditions aside from autism, having a diagnosis of depression or anxiety, we found that autism diagnosis and autistic traits explain significantly more variance, so significantly more about suicidality than any of these other risk markers alone. And we also identified some important unknown risk markers in autistic people. So one that has never been included in any suicide research at all is camouflaging. So camouflaging who you are, camouflaging your autistic characteristics in an aim to fit in better with others. Having unmet support needs, which we know from our sample are really, really prevalent, as in the earlier study that I showed you, people like me don't get support, and non-suicidal self-injury as well. And we're really, really interested in, you know, what is it about camouflaging, social camouflaging, that increases risk of suicidality? And we thought about this in context of the model that I showed you, the interpersonal psychological theory, particularly in relation to belongingness. So we initially looked at this in 160 undergraduate students. We used the newly developed Camouflaging Autistic Traits questionnaire by Laura Hull and colleagues to measure this construct of social camouflaging. And you can look at different components of camouflaging. So you can look at compensation, for instance, for autism-related difficulties in social situations, and also assimilation to fit in with others and not stand out from the crowd. And this assimilation kind of component of camouflaging that's covered in this questionnaire is very, very similar to the concept of thwarted belongingness. And we thought that perhaps they could be related, and we know that they're associated with poor mental health. So we asked in this study, do people with high autistic traits, regardless of autism diagnosis or not, try to camouflage those traits to try and fit in? And does that lead to increased risk of thwarted belongingness and suicidality? And we found that yes, that is the case. And that's what these kind of diagrams show, that autistic traits are related to camouflaging, which are in turn related to thwarted belonging, in turn to lifetime suicidality. And we found that this was an indirect relationship. So the effect of, or the association with camouflaging to suicidality has to go through thwarted belonging. It's not direct along this dashed line here. And we found that assimilation, this assimilation component, not trying to stand out, which is kind of an important part of camouflaging, was even more strongly related to thwarted belonging and suicidality than the overall camouflaging score. So it's that not trying to stand out from the crowd that's really strongly associated. So far, we found that the interpersonal psychological theory of suicide could have relevance to autistic people and those with high autistic traits, regardless of autism diagnosis, in explaining increased risk of suicidality in this group. I think what we found is it's really, really important not to inadvertently encourage camouflaging autistic traits in autistic people, because it can really kind of fuel these feelings of thwarted belongingness, not being accepted for your true self in a largely neurotypical society. So the next steps for this, we have a number of things to look at, and these are kind of the first steps. We want to know, are there unique risk markers for death by suicide in autistic people and those with high autistic traits, regardless of diagnosis? And we're coming to the end and starting to analyse data from the first psychological autopsy study, where we've actually analysed different risk markers by talking to people who've lost a loved one to suicide and looking at coroner's inquest records. And what we're finding preliminarily, because we haven't finished our analysis yet, but what we're finding is increased rate of anxiety diagnosis, social isolation, and reduction in service contact in autistic people and those with high autistic traits compared to non-autistic people. We're finding lots of similar risk markers. There are lots of similarities because non-autistic people who die by suicide experience a lot of the similar risk markers that autistic people do, things like homelessness, living alone, increased alcohol and drug dependency, bereavement, history of self-harm. And what we're finding is that it's not one risk marker, but it's rather a similarly high number of a range of risk factors together, because suicide is really, really complex. We'll never kind of know why a single person might choose to take their life, but we know that it's a number of different complex varying risk markers unique to the individual, and that's what we're really finding in this study as well. So we're nearly there for submission, so please, if you're interested in this study, then please get in contact with me, and we hope to publish the results quite soon. And another thing that we really need to do is to explore what differentiates autistic people who think about suicide from those who attempt suicide. And that isn't something that we have done sufficiently, I don't think, in previous research. We're looking at broader risk markers, which makes sense as a first step, but we really need to move on to this question as quickly as possible so that we can better intervene and predict who may attempt suicide, who's at real risk. So how can we best identify and assess suicidal thoughts and suicidal behaviours in autistic people in research and clinical practice? This was another key priority for the autism community. And I'm going to talk about some of our work that we've done looking at evidence for measurement properties of tools in autistic people and adapting suicidality assessment in partnership with autistic adults. And we know that this is so important from what I presented of Mirabel's work, that we need these measures to work if we're to move on to developing our understanding and models and understanding why autistic people are more at risk. So this is part of the Mental Health Autism Project, which was aimed to develop a brief assessment tool to better identify suicidal thoughts and behaviours in partnership with autistic adults. And it's key to note that this is mainly for use in research, like in the studies I talked about previously, looking at models. And it was consisted of 3 stages. So are there validated tools available? What are the measurement properties of the candidate tool? And what are the measurement properties of the adapted tool? So in the initial stage of our project, we did a systematic review, and we were really shocked again because there were so many studies, so many more studies that looked at suicidality in autistic people, but not one had used a tool with any evidence of validity. But we did identify a tool that had been widely used in the general population, non-autistic people, that could be really useful to consider adapting for autistic people. And that was called the Suicide Behaviours Questionnaire Revised. And you can see in this kind of highlighted red row showing the SBQ-R that these pluses, the more pluses there are, the more evidence in support of a measurement property. And you can see, compared to some rather expensive tools that are available, the evidence is much more consistent and much more strong in support of this tool for research compared to others. So that's why we decided to see whether it would be useful for autistic people. So in our first study, we explored what's the evidence regarding how appropriate this is for autistic people. And we used a large online survey to gather a large number of responses in autistic and non-autistic people to this questionnaire, the SBQ-R. And then we followed up with interviews with the subsample of participants and another survey to get feedback and try and figure out how autistic people interpreted the items and how to adapt them. So there's 4 questions on the SBQ-R that tap into experience of suicidal thoughts and suicidal behaviours. And we predicted that there were 2 items that could pose particular difficulty for autistic people, particularly items 3 and 4. So item 3 asks about threat of a suicide attempt or communication of suicide intent to others. And in talking to our steering group, our autistic steering group who are advising on the project, and in a public engagement event that discussed this tool in partnership with autistic people and those who support them, they said that a lot of autistic people could experience suicidality but not necessarily communicate it to others because of difficulties in social communication, because of social isolation, for instance. So this might not be, we would predict, and might not be as related to the construct and the other questions in autistic people compared to non-autistic people, because it's not really capturing what it's supposed to capture in this group. And the other item, which our partners said could be particularly problematic, is item 4. So self-reported likelihood of attempting suicide someday in the future, because of the abstract nature of the question and the difficulty and kind of, well, anything could happen in the future, so how can I answer this question? And we found evidence for that when we compared the structure of this tool between autistic and non-autistic people. We did find evidence that these 2 items were the ones that were particularly interpreted differently by autistic compared to non-autistic people. And when we interviewed people, autistic people, it kind of explained these differences and reiterated what our steering group and people at public engagement events were saying. So they said that there's something missing for item 1, so something missing between having a brief passing thought and having a plan to attempt suicide. They said that for item 2, this which asked about frequency of suicidal thoughts in the past year, that very often 5 or more times does not capture the intensity of the thought or the length of time, doesn't capture their experience, and it made them question their own suicidality, like, am I really bad because I'm nowhere near the end of the scale. And for item 3, as we expected, they fed back that who would you tell? It's an important question to ask if you're going to if you have told somebody that you intend to take your life, but I don't have any opportunity to do this. And they also fed back on the sensitivity of this question and the appropriateness of language. And for the last question, how likely is it that you'll attempt suicide someday? They said it's a future question. You don't know what's going to happen in the future. It's important, but it's impossible to answer. So we adapted this tool with feedback from the same people who took part in those initial interviews and a further Delphi survey to get further feedback on the adapted tool. And then we did a validation survey on the adapted tool. So these are the adapted adaptations that we made. So for item 1, we simplified the response options. We put in a stage between a brief passing thought and a plan. And we included follow-up questions that aren't scored, but about impulsivity, planning, understanding planning, and access to means. We also changed the frequency questions to help gather the full frequency and intensity of suicidal thoughts in the past year, and capturing perseverative suicidal thoughts as well, like thoughts that won't go away, which is something that a really consistent theme in our feedback. We also tried to make the question about future suicidal attempts and likelihood more concrete. And this was actually a question that was suggested by a number of autistic people that took part in our studies and provided feedback. And a lot of them, autistic people, also suggested including a visual aid to help quantify, what does very likely mean or very unlikely. It's important to note that about 50% of people who took part found this visual aid useful and chose to use it. Some people just really don't like it, and some people, do like it and find it useful. And not only autistic people, also non-autistic people opted to see this and found it useful. So it's good to provide people the option. And we also included communication of intent and past attempts, and changed language to try and make it more sensitive and more specific. And we also included follow-up questions on suggestion from our autistic partners, such as who did you tell? And why have you never told anybody? Is it because you're socially isolated? Is it because you're scared to tell anybody? Is it because it's too difficult to tell people? Is it a communication difficulty? And that's something that's really important for clinicians and researchers to explore further. Why is it that autistic people can find it difficult to tell others about their suicidality? So we found a lot of evidence in support of the measurement properties for this tool in autistic and non-autistic people. We found evidence for equivalence of this tool, so equivalent kind of structure of this tool between autistic and possibly autistic adults. So that's autistic adults that haven't been diagnosed but suspect very strongly that they are autistic. So this tool can be used with autistic people regardless of diagnosis, which, as I said from the beginning, I think is really important because there's so many undiagnosed autistic people that are likely coming into contact with services who've experienced suicidality and need support. So this tool needs to work for them in research and clinical practice. There's evidence of a different factor structure, so a different structure in autistic and possibly autistic people compared to non-autistic people. So this tool can't be used to compare between autistic and non-autistic adults. And we know from a lot of previous research that this is very much the case. It's very difficult to get a tool that will work and be interpreted in exactly the same way by two different groups with very different perceptions and experiences. And we also found evidence for equivalence regardless of gender and use of visual aids. So we don't have to worry about, having to use different tools for people of different genders or different preferences for seeing that visual aid for item 4. We also found that this tool is significantly associated with lots of other relevant constructs, and it's really sensitive to detecting autism relevant constructs compared to the original tool. So it's more closely related to autistic traits compared to the original version. So it seems to be more sensitive to that, which makes sense because this is an autism adapted tool. We also found that it's really stable over time. So if you fill this out at one time and then 2 weeks later, the scores are really similar, really high correlation. And we also found that it correctly classifies 88% of autistic or possibly autistic people who reported lifetime suicide attempts, according to item 1 of the original tool, which is really excellent sensitivity and specificity in research. So in partnership with autistic adults, we have adapted a widely used tool to better capture suicidality in autistic and possibly autistic people. We've got an evidence in support of a range of measurement properties, and we can use it to compare autistic and possibly autistic people without, regardless of diagnosis. It's used well, validated in research at the moment, but it could be useful for opening conversations in clinical practice. But it's just really, really important to remember that these kind of short tools are a very poor predictor of future suicide attempts when used alone. It's open source, and if you want a copy or you want to know more information about it, then please email me. And I just wanted to very briefly tell you about next steps. So we know that this is a brief self-report tool, and there are lots of problems with that. It's very, very useful for a range of research, but we know that we're going to need other tools to enable us to answer that question, like what's the best tool? We need to have a range of different assessment strategies for different contexts that are validated for use in those different contexts. And another thing that we're developing and adapting right now is the card sort task for self-harm in partnership with autistic people. And that can look at patterns of self-harm over time and relationships and differences between two groups. And we've been supported by INSAR. We're funding from INSAR to do that, and we're in the progress of doing that now. So just in summary, suicidal thoughts and behaviours are significantly higher in autistic people compared to other groups. Late diagnosed and undiagnosed adults without intellectual disability appear most at risk. We know now that autistic people experience increased vulnerability to known risk markers for suicide, such as reduced sense of belonging and isolation, difficulty accessing support and treatment for mental health conditions and suicidality. But also there are gaps and things that we don't know yet, and things that we have discovered that is perhaps specific to autism and beyond comorbidities, such as social camouflaging and social support. And I think a key message across all of this is access to appropriate treatment support is life-saving, but it's really, really difficult to access for autistic people. And that is something that we absolutely have to address. And that's a top priority. So what barriers do autistic people experience when seeking help, which might put them at greater risk of suicide? Really need to tackle this question. It's very, very underexplored. We have made progress on the bolded questions, but look at all of these unbolded questions, such as how do autistic people seek help when they're in a crisis? How should interventions be adapted for autistic people in individual presentations? There's so much to do. I'd just like to thank everybody who's joined me on this journey, and I couldn't fit everybody's pictures onto this slide. There's so many people that have helped me with this, and I also include a picture of the top 10 priorities and the people involved that all look really, really justifiably happy after this amazing achievement, and all of the funders who've assisted and supported my research. And if you have any other questions, then please email me or follow me on Mental Health Autism. And I'd just like to reiterate that I know I've talked about some really, really tricky topics, so I hope that you will all take care of yourselves and be kind to each other and be kind to yourself. And also remember that in the chat, Autistica staff have added a link to further support if you need to talk to somebody. So I hope that you're okay and that you found my presentation interesting, and thank you all so much for listening.
Great. Thank you very much, Sarah. If you could unshare your screen. So you do that on the top and the.
Yeah. Okay, I see.
Yeah, perfect. That's great. And I will share my screen. So I just before we move on to question and answer sessions, I just want to say that there are helplines available. We're aware this is quite a difficult and for some people distressing topic to consider. So just if you are wanting to reach out for support or some help, Samaritans have a helpline on 116123, or you can email them at joe@samaritans.org. That's joe@samaritans.org. And we've also put a range of other helplines up in case they're useful, and they're in the chat function as well if you want to access those. So I'll just keep those up for a moment, and then we'll and then we'll move on to the question and answer session. Great. So Sarah, we've got a lot of questions, and we don't have a lot of time. So I think we'll maybe just answer a few of those, and to everyone who's very kindly submitted the questions, what we'll do is we'll see if there's a way in which we can get back to you on those, or is in our format through which we can address issues, because so many of the questions are really fantastic. So I think this related to the first question relates to a question, a community priority actually, which is, you know, how do you get a doctor to take you seriously when you do have suicidal thoughts or beliefs? Have you got any insight or understanding on that issue?
Yeah, I think it's excellent and really, really important question. It's something that I've talked about a lot with other autistic people. And I suppose one of the things that we've tried to do is we've actually developed some guidelines for GPs that we co-produced with autistic people to try and address this exact issue. Because we have to educate health providers more about how autistic people can present with suicidal thoughts and behaviours in a slightly different way. And I'll give an anecdotal example, but it's actually something that's shared by a lot of autistic people. I don't know if it's specific to your experience, it might not be, and that's okay, but it's just an example that was included in our guidance, and that is that clinicians aren't perhaps ready or aware that autistic people might be so used to camouflaging that this actually comes out when they're comes into play really when they're trying to disclose their distress and suicidal thoughts and behaviours to another person, and it means that the way it's communicated isn't what the clinician expects, and perhaps they they kind of think that it's a lower risk than it is, because if you're so kind of used, and this is what our steering group described, if you're so used to camouflaging your distress in everyday situations, then when one of our steering group members actually disclosed suicidal thoughts to their GP, she smiled when she did it. And she was just so used to putting on that kind of so used to camouflaging, and that meant that the GP or the health professional didn't take it seriously enough in her view. And I think that's quite a common experience, and I think that we have to educate clinicians to adapt to those kind of things and educate them about them, and that's one of the things that we've tried to do in developing guidelines.
Great, thank you. That's really useful advice. So we've got a question in just around how suicidality and suicidal thoughts and suicide functions in respect to different demographic characteristics. So do you have any understanding of how this relates to age or gender or anything like that?
There's limited evidence at the moment, but I think the stronger evidence comes from the large population studies, which showed that autistic women without co-occurring intellectual disability are significantly more at risk of dying by suicide compared to non-autistic women. And that's a very, very different gender profile to the general population where men are at risk. So there seems to be a really heightened risk of suicide in autistic women without co-occurring intellectual disability. There are a few developmental studies looking at age, but there are some very recently published studies that have looked at age, and there does seem to be an association with kind of older age being associated with increased risk of suicidal thoughts and behaviours, but it's quite preliminary. And aside from that, the issue is, and this is a lot of autism research, it's getting suicidal thoughts and behaviours are rare behaviours. So, and also you're looking in a subgroup of autistic people. So it's very, very challenging for researchers to get large enough samples of autistic and non-autistic people to look at these different kind of subgroup characteristics and the role that they have in increased suicide risk. So national studies are the real way to address that, and we need more of those, and we don't really have them at the moment.
Sure. Yeah, that sounds really important. So I think we're only going to have time for one last question because we're already running over slightly. This is a question from Gemma. How do you see this tool being used in clinical settings for undiagnosed autistic people? And do you envisage it replacing the current tool and being used for everyone?
I don't envisage it being replaced with the current tool for everybody, because there are, differences in the way that autistic and non-autistic people respond to the questions. What I would say is that according to our research, there seems to be a lot of people who present with suicidal thoughts and behaviours who also report really, really high autistic traits. And where our tool could be really, really useful is when clinicians think that this person might have high autistic traits regardless of diagnosis. Because our tool, the way it differs from the original, is that it really captures those perseverative suicidal thoughts that won't go away. And it provides more concrete ways of somebody with high autistic traits or autism diagnosis to indicate whether they intend to make a suicide attempt in the near future.
Thank you. That's really helpful. So I think at this stage we're running slightly over, and I'm aware that that was quite a difficult topic to discuss, which you discussed extremely sensitively, and it was a really interesting and important talk. So thank you very, very much, Sarah. I really hope that I'm really certain that the work that you're doing is really going to change what is a really urgent and tragic issue. So for people attending online, we've got a talk with Jacqui coming up, and that's scheduled for 10 past. I'm going to say we're going to start at exactly 12 minutes past, because I think it's important that we all have a 10-minute break before we get started again. And so then after Jacqui's talk, I will do a short closing speech, and we've got an award to give out, and then that will be the end of the festival. So we'll see you back in 10 minutes at 12 minutes past. Thank you. Hello everyone, thank you to those of you who have joined us. If you're just joining for Jacqui's talk, just to let you know that we're just starting at 12 minutes past, just to give everyone a chance to properly join us, and because we finished the last talk slightly late. Hi everyone, thanks for joining us. We'll just be getting going with Jacqui's talk in 1 minute. We're just giving everyone a chance to rejoin us. Great. Well, thank you everyone for joining us for the second keynote talk of the day. Jacqui, are you with us as well?
I am, but I'm unable to start my video. It says the host has stopped it, so I think
that's okay. Bethan will enable that in just a moment, and then we can, and then we'll be able to get started.
Yeah, that should be fixed now.
Great. Hello.
Hello.
Great. Right. So, our next speaker is Professor Jacqui Rogers. So Jacqui is a psychology and mental health and an autism researcher at the Institute of Population Health Sciences at Newcastle University. Jacqui leads a program of work which aims to advance the conceptualization, assessment and treatment of mental health conditions in autistic children and autistic adults as well. So, Jacqui has a particular interest in anxiety and autism, and with colleagues at the University at Newcastle has developed the first ever anxiety questionnaire specifically aimed towards autistic children. Jacqui's also led the development of a number of different psychology interventions for co-occurring mental health difficulties in autism. So that includes conditions like anxiety and depression, as well as issues like suicidality. Much of Jacqui's work has focused on managing uncertainty, and that's what Jacqui will be talking about today. So the title of Jacqui's talk is Exploring the Unknown, Uncertainty, Anxiety and Autism. And I will now hand you over to Jacqui, who can do her talk.
Thank you, James, and thank you to Sarah, of course, for a fantastic talk. She's always a hard act to follow, but I'll definitely do my best. And thank you for inviting me to speak at this festival. When I agreed, I thought it would be face-to-face with everyone, and it's turned out to be very different and a little bit scary in terms of the technology, but hopefully, fingers crossed, things will work okay today. So throughout the conference, we've heard a lot about anxiety in autism, and there are clear reasons for that, and that's going to be the focus of my talk today. We know, sadly, that anxiety is a very common experience for autistic people, for both children and adults. We also know from a variety of different studies that when anxiety is experienced, it's often complex, with people presenting with multiple types of anxiety presentation concurrently, which makes developing treatment protocols really challenging for those individuals, because kind of where do you start with a really complex picture? We also know from our work and the work of others that anxiety often is not consistent in its presentation with traditional DSM neurotypical kind of nosology in terms of anxiety subtypes. And we know from priority setting exercises such as the one led by Autistica a couple of years ago, that tackling anxiety is a really important research priority for the autism community. Now, of course, in order to make progress in this area, we need to develop a really clear understanding of the constructs that contribute to anxiety for autistic people. And we need to do that in order to inform assessment methods and also to inform intervention programs. And it's the intervention bit of that I'm going to be focusing on mainly today. Now, of course, for anybody, there's going to be multiple paths to anxiety, and the work that I'm going to present to you today isn't trying to claim that this is the sole underpinning construct that's important to anxiety, or that it's the absolute answer to all of the questions that we have. But what I'm going to share with you today is some work that we've been doing looking at the relationship between uncertainty and experiences of anxiety for autistic people. Now, when we feel uncertainty, when we're in an uncertain situation, of course, we have less knowledge about that situation than we would like. And in an uncertain situation, it's very difficult to predict exactly what's going to happen. And anxious people tell us that they really dislike feelings of uncertainty, and they find uncertain situations really challenging and difficult. And they also tell us that this is because uncertainty can often reduce feelings of safety. So feeling uncertain, having that experience of feeling uncertain, and makes somebody feel unsafe. It can increase feelings of threat in the environment. Feeling uncertain consistently and over long periods of time or very frequently will reduce resilience, and it can lead to anxiety. So for these reasons, we're interested in exploring the role of uncertainty in relation to anxiety experienced by autistic people. Now, the notion that uncertainty is related to anxiety is not a new thing, and it's not something that's specific to autistic people. The role of uncertainty in anxiety presentations has been talked about for quite a while now. It was first identified by a group of Canadian researchers led by Michel Dugar way back in 1994, when they were developing a model of generalized anxiety disorder for general population adults. And you can see the kind of depiction of their original model there on the screen. In developing this model, they came up with this idea of intolerance of uncertainty as an important process variable that underpins pathological worry and anxiety in a kind of generalized presentation. And this idea of intolerance of uncertainty has been researched extensively in the general population in the subsequent years. It's a bit of an outdated term, I think, but essentially it's relating to kind of dislike of the unknown or dislike of difficulty with uncertain situations. People who have high levels of intolerance of uncertainty or struggle with uncertainty find uncertain situations to be very stressful and upsetting and feel very threatening. And as a consequence of this, uncertain events are often believed to be negative, even if they themselves don't have a negative potential outcome. Just the feeling of being uncertain is regarded as negative. And consequently, people may avoid uncertain situations if they possibly can in order to avoid this uncomfortable experience that they have. And we know now from the work that's developed since 1994 that difficulties with uncertainty are believed to contribute to a range of mental health conditions and be important across a range of anxiety disorders. So although it was initially proposed as a construct in generalized anxiety disorder, we now know that it underpins separation anxiety and social anxiety, etc. And given that autistic people present often with characteristics or symptoms of a variety of anxiety disorders concurrently, looking at a transdiagnostic construct, something that might feed into all these different types of anxiety disorder, might be quite a useful thing to do. So we've been interested in looking at whether difficulties with uncertainty might contribute to anxiety experiences for autistic people. And we began doing this in about 2012 in the Christina Bolter paper that you can see on the screen there, where we looked at whether intolerance of uncertainty was identifiable in autistic children and related to anxiety in the same way that we seem to think it is in the general population. And the short answer to that is yes, that is the case. So we found high levels of anxiety in the autistic children that we worked with. We also, for the first time, were able to demonstrate high levels of intolerance of uncertainty and an important and strong relationship between the two. And since that initial paper, there's been a flurry of papers over the years looking at difficulties with uncertainty in relation to anxiety and autism. And one of the most recent papers, and a lovely paper by Hannah Pickard and colleagues, is kind of getting a bit more specific than we were able to do in that first paper by looking particularly at the role of uncertainty in relation to social anxiety for autistic adolescents and neurotypical counterparts. So I would recommend that paper wholeheartedly. If you're interested in reading more about the kind of growing evidence base of the relationship between uncertainty and anxiety and autism, it would be a good idea for you to check out a recent lovely meta-analysis by Richard Jenkinson and colleagues from the University of Sheffield, in which they've kind of evaluated the evidence for this association. And the kind of take-home message from this, this really nice piece of work is that a strong relationship appears to be in evidence across a range of studies in relation to anxiety and uncertainty for autistic adults and also autistic children. In addition to that, and really importantly, I think, because I guess, you know, if this relationship exists, what impact is it having on individuals and what impact does it have on our capacity to help individuals who are experiencing anxiety? And a study carried out by Amy Kiefer and Judy Reaven and colleagues a couple of years ago really helps us to maybe understand the importance of thinking about difficulties with uncertainty in relation to anxiety. They were interested in evaluating a very well-established manualized CBT-based intervention for anxiety developed for autistic children called Facing Your Fears. It's got a really strong evidence base. It focuses on worry and it doesn't focus at all really on uncertainty, but they were interested to see what role uncertainty might have in the kind of effectiveness of their intervention. So they assessed uncertainty, tolerance of uncertainty at baseline for their participants, and then again at the end of the study. And what they found was that higher levels of difficulties with uncertainty at the beginning of the study predicted poorer treatment response for these children. In other words, those children who had high levels of uncertainty-based anxiety didn't fare so well in this very kind of well-established intervention program. And what this suggests to us then is that perhaps targeting responses to uncertainty for autistic children may improve outcomes when those young people are experiencing anxiety. Perhaps we need to directly target this uncertainty mechanism. And so over the past few years in our group, what we've been doing is trying to do that. And we've been doing that by developing a range of related intervention programs, all under the banner of coping with uncertainty in everyday situations, or CUES, as I'll refer to it. And what I'd like to share with you today are some examples of 4 of those intervention programs under the CUES portfolio, if you like. They're all at very different stages of development, and some of the data that I'm going to show to you is very, very recent, i.e. in the last couple of weeks it's emerged. Some of it is very early pilot data, as you'll see, but hopefully you can see this emerging picture from our work that perhaps addressing uncertainty might be useful clinically when trying to support some autistic people experiencing anxiety. So the Coping with Uncertainty in Everyday Situations program, there are a variety of different versions of that now, but they all kind of have the same underlying principles. So they're delivered in different ways to different groups of people, and they use different techniques, but the principles remain core and at the heart of each of those variants. The first principle is that unfortunately we can't make the world an entirely certain place. As much as we would want to in order to reduce distress and reduce anxiety, that's simply never going to happen. And of course, the current situation that we're in with the coronavirus is a prime example of that sometimes uncertainty happens and it's not controllable and we can't reduce it. And so in that sense, it's really important for us to try and build up skills, strategies and techniques in individuals to try and help them to cope with everyday uncertainty. And in that sense, tackle this uncertainty mechanism to try and build resilience in the face of unavoidable uncertainty. So the CUES program in its variety of forms helps individuals to develop strategies to cope with and manage everyday uncertainty, and to reduce reliance on strategies that aim solely to reduce uncertainty. And kind of aiming to reduce uncertainty is an entirely natural thing to do, and we all do it from time to time. We might avoid uncertain situations, we might over-prepare for uncertain situations, or act impulsively to get rid of that feeling of uncertainty. And all of those strategies may have a place in our lives, but sole reliance on them, of course, is not going to be particularly helpful because we can't always reduce the uncertainty in our environment. And also underpinning the CUES program, very importantly, and I think this message has come across in a number of talks over the course of the last week, we need to take a personalised approach to mental health interventions for autistic people, and that's embedded at the heart of the CUES program, and I'll hopefully illustrate that a little bit as we go through. So our first journey into CUES was published a couple of years ago now, and some of you may be familiar with this. This is the CUES Child Programme. This is a parent-mediated group, so the parents attend, not the child. It's been developed for parents of autistic children aged between 6 to 16. Parents attend in groups of around about 6 to 8 parents at any one time. They attend eight 2-hour sessions, mainly more or less weekly. The overall goals of CUES are to help parents to understand their child's experiences in relation to uncertainty and notice uncertainty and how their child responds to it, and to help the parents develop a range of strategies for uncertain situations so that they can then go out into the world with their child and promote and encourage and develop the use of those strategies by their young one. The way in which we do this is very personalised and developmentally appropriate. So the therapist will work one-to-one within these groups with the parents to develop strategies that are appropriate for their child's level of development, their age and their interests. We produced and published some very preliminary findings of our pilot study, which you can see on the screen there, in around about 2017. And the important figures here in this table are the ones in bold there, which are the pooled effect sizes for the CUES intervention. So as you'll see, we delivered the intervention to 2 groups. The first was a group of community recruited families, and the second group was a group of families recruited through child and adolescent mental health services. Very small numbers, of course. This is a pilot study, so we can't make any grand claims about effectiveness. But what we can see when we look at parent-reported child difficulties with uncertainty and anxiety is some reduction in scores over time with kind of small to medium effect sizes, indicating that CUES might be having a positive impact on these particular constructs and is worth exploring further. And that's what we've been doing. So with the kind funding from Autistica, we are just coming to the end of a pilot randomized control intervention feasibility trial of CUES Child. being overseen by the wonderful Jane Goodwin. We have 50 families randomised to either receive our Cues child intervention or an attentional control. And we're primarily interested in the feasibility and acceptability of the intervention. So feasibility in terms of, can we deliver this through NHS services? That's what we're trying to do with NHS therapists. And is it acceptable to families and also to service providers? We have some secondary outcomes, of course, around the child's ability to manage uncertain situations at the end of the intervention, and of course in relation to anxiety. We've just got our final data from the families who've been working with us. We've been slightly delayed because of COVID-19, but we're hoping to publish those data very soon, and we'll be able to evaluate whether Cues child is seen as feasible and acceptable, and kind of take the next steps from there. If anyone is interested in finding out a bit more about Cues child, we do have the published protocol paper, which goes into a bit more detail about the intervention and also, of course, our outcome measures. Now, when we developed Cues child in collaboration with parents, and then we did our initial evaluation of it, we worked very closely with parents of autistic children without co-occurring intellectual disability. Now, of course, there's emerging evidence that children who have an autism diagnosis and also have co-occurring intellectual disability also experience anxiety. And there's been a few papers recently suggesting that uncertainty may have a role to play in the anxiety experiences of these young people too. So we're really keen to see whether we could work with parents of autistic children with co-occurring intellectual disability to adapt Cues to make it suitable for that population. This is often a kind of hidden or an under-resourced population, as I'm sure you know, and we're really keen to try and make our interventions as inclusive as possible. So this work has been led by Jessica Maxwell, who worked with a range of different organisations, including a fantastic charity in the Northeast called Sparks, to interrogate really parents of autistic children with co-occurring intellectual disability about the difficulties with uncertainty that these young people might be experiencing, and the kind of strategies that parents are currently using to manage those difficulties. And on the basis of that really important information, Jessie went on to adapt Cues, and we've developed Cues 2, which is a version of the programme for children with a co-occurring intellectual disability. And we've just undertaken a really small pilot evaluation of the acceptability and feasibility. Now, these are unpublished data, data that have emerged in the last few weeks, but I thought it might be interesting to share some of them with you. So these are some of the things that Jessie's done in collaboration with parents to adapt some of the Cues materials to make them more suitable for this group. So lots of use of symbols, of picture stories, and providing choice in terms of scaling and working with what's meaningful for the child rather than what we would ordinarily just choose to use as researchers. So embedding choice and making lots of options available to families so that they can tailor the way they work with Cues to make it developmentally appropriate for their young person. So Jessie undertook a really small pilot study with one group of Cues 2 families earlier in the year, and she delivered Cues, so it's still a parent-mediated group, 2-hour sessions over 8 weeks, but adapted materials. And then she followed these families up at 6 months and then at 12 months. There was 5 families in the study in total, so it is a very small sample size. And what you can see on the screen there are the effect sizes for change in key outcome measures from these families at follow-up. So we assessed intolerance of uncertainty in a couple of ways for these families. We used the intolerance of uncertainty scale parent version, which is the one we've used previously and the most widely used parent report tool. But it's really been developed for children without co-occurring intellectual disability. So we also used an additional tool called Rules, which also taps into difficulties with uncertainty, but from a more kind of behavioural perspective, to see whether that was more appropriate for this group. And we also assessed anxiety. And what you can see on the screen here are the effect sizes. So that's the amount, again, that things have changed from baseline to follow-up in relation to these key outcome variables. The numbers are too small to do any fancy statistics, as you can imagine, but we can look to see the magnitude of change over time. And the bigger the number, the larger the difference between pre and post. So that's a key thing in terms of reading effect size data. And what you can see here on the screen, if we look at the emboldened column, is a large magnitude change in intolerance of uncertainty for the child as rated by the parent at 6 months, and a smaller, more modest change in child anxiety 6 months after the delivery of CUES-2. If we move to the 12-month data, what we can see 12 months after the end of the intervention, large differences between baseline and follow-up data for uncertainty, and now a medium-sized difference for anxiety. So it looks as if the changes we're seeing in uncertainty have been maintained, and actually the differences have got bigger at 12 months. And subsequent to that, we're seeing now a reduction in anxiety at 12 months for these families. But of course, you know, that's with a caveat of very small numbers. Now, one of the benefits of working with small numbers is that we can actually look at individual participant data. So these are the participants in CUES-2 and their individual anxiety scores and uncertainty scores at baseline 6 months and 12 months. Now, whenever we give questionnaires to people, of course, there's going to be some measurement instability in the questionnaires. There's going to be some fluctuation in how people respond to those questionnaires, just by a consequence of the properties of the questionnaire over time. So it's important when we're looking at change for us to be confident that any change in scores that we're seeing over time are over and above what we would be likely to see just as a consequence of that measurement instability. And that's called reliable change. And so what we can see in the dark blue boxes here on the screen are changes in scores on these 3 measures that are reliably, changing reliably, so over and above the kind of likely instability of the measure. So if we look at the 2 uncertainty measures there, we can see quite a lot of reliable change across participants at 6 months from end of intervention, and then again at 12 months. So these are scores that are diminishing over time, over and above these natural fluctuations. And we can see for 2 of the participants a reduction in anxiety scores also over time, over and above what we would expect due to measurement and reliability. Now, of course, what's important is whether these changes in scores are actually making a difference clinically. That's really what we're interested in, isn't it? And for some of these scores, what we can see as well as change over time is clinical change. And what that means is that a score at baseline which was above a clinical threshold, above a clinical cutoff, has now fallen below that clinical cutoff. So the boxes in yellow there indicate scores for children where their initial baseline scores were above a clinical cutoff, and they're now scoring below that cutoff. So that would give us an indication that there's been a clinical change in relation to responses to uncertainty and to anxiety for these young people. So I've talked a bit about children so far and the CUES Child Programme, but of course we know that autistic adults also experience significant anxiety, and there's an emerging literature base looking at the underlying constructs that may contribute to anxiety in adulthood. And intolerance of uncertainty and difficulties with uncertainty do seem to feature in that literature as being an important variable for us to think about in relation to anxiety as experienced by autistic adults. And there's one example of a paper that's looked at that on the screen there, but there are others that it would be useful for you to read if you're interested in this topic. So we're interested to see whether we could develop a version of cues that was appropriate for autistic adults who are experiencing anxiety. And of course, a parent-mediated group would be completely inappropriate. So what we did a few years ago now was we took the principles of cues that I talked about at the beginning, and we developed a delivery method that would be more suitable to adult participants. And this is kind of a bit unimaginatively been called Cues Adult. And these data have already been published. So this is from a paper a couple of years ago now, describing the development and the initial findings in relation to Cues Adult. So this is a single case experimental design study in which 4 autistic adults participated. Now, the key thing with single case experimental design is that traditionally there are kind of 3 phases to the study. There's the first phase, or A, as depicted on that figure there, which is the baseline measurement. So for your constructs of interest, your outcome measures, you ask participants to report on those measures over a series of days, so you can find out what their kind of baseline levels are in relation to the constructs of interest. So that's the baseline phase. And our primary outcome for the Cues Adult study was a target uncertain situation that was developed and identified by the adult participants as being something that they found bothersome or distressing in their everyday lives that they wanted some help to try and address. So these were very personalized targets. These were noted at the beginning, and then the participants responded on a daily basis using daily diaries, reporting on the level of anxiety caused by that situation, their confidence in managing that situation, etc. We did this over a period of weeks, so we got a kind of stable measurement at baseline, so we knew where they were starting from. The next phase of single case is the intervention phase. So during this phase, phase B, we had one-to-one CBT-based weekly sessions with the 4 adults, focusing on uncertainty around this target situation and trying to promote the development of strategies to cope with that situation a little bit better. And then in the final phase of the study, phase C, we have a 1-month follow-up. So the intervention stops at the end of phase B. The participants continue with their daily diaries as they have done throughout, but they're not receiving any intervention. And of course, that's the follow-up phase. In addition to the target uncertain situation diaries, we also asked people to report on a number of standardized outcome measures, assessing depression, anxiety, uncertainty, and stress. So the data that you can see on the screen now are the data that you would extract from those daily diary graphs that you saw an example of on the previous screen. So these are individual participants, and this is around their confidence in managing their personalized target uncertain situation. So the first block here, phase A to phase B, baseline to the end of treatment, and then phase C is the end of treatment to the end of the follow-up. And the key numbers here are the ones in red. So these are when we combine the 4 participants' data together, and we can look to see whether there's significant change in their confidence in managing this uncertain situation at the end of these 2 phases. And what we can see is that there's a significant improvement over time from baseline to the end of therapy, and that this is maintained until the end of follow-up. So this is giving us some indication that Cues Adult may be helpful. And then if we look at the standardized outcome measures, and we do that in the same way as we looked at Jessie's data for Cues 2, we can look at clinical and reliable change here across these 4 participants, comparing baseline with the end of follow-up here, so baseline to 1 month. And for depression, we can see clinical change for 2 of our participants. So they went from scores that were within the clinical range to the non-clinical range. And this is the case for 1 participant in terms of anxiety. For another participant, we can see reliable change. Their scores were below the clinical cutoff at the beginning, so they couldn't drop below it at the end because they were already underneath it, but they are reliably changing. In terms of responses to uncertainty, we see clinical change for 2 participants and reliable change for participant 3. So their score's still above clinical cutoff, but it's come down quite markedly. And in terms of self-reported stress, we see reliable change for 3 out of 4 of the participants. So again, this is giving us some indication that a Q's adult is having an impact on individuals' ability to manage anxiety that's related to uncertainty. Now, so we've talked about children, we've talked about adults. When we were doing the child study, it became apparent to us that there was some young people, some autistic young people who were receiving interventions in CAN services for anxiety, for whom the child parent-mediated group wasn't appropriate. And that was either because these were adolescents who were really not keen on the idea of mum or dad heading off to a group every week to talk about them, or it was just really tricky for the parents to participate in the parent-mediated group. You know, going along to a 2-hour session every week for 8 weeks is a big commitment for families who are very, very busy or working. So we were conscious that we wanted to try and develop something that would be appropriate for autistic adolescents. And part of the reason for that also was because we began to do some work exploring directly with autistic adolescents the role that they thought uncertainty might have in their lives in relation to anxiety. And that's the Joyce paper that you can see on the screen there. So we were interested in finding out whether we could take our Q's adult program and do a kind of downward extension and make the materials appropriate for use with adolescents. So the kind of delivery was the same. It was one-to-one, traditional talking therapy type delivery, but we tweaked the materials so that they were much more appropriate for adolescents compared to adults. And this is work that was led by Renske Herrema, who was also involved in the adult development study. And we used the same, we've used the same study design for the Q's adolescent program. So single case experimental design. So exactly the same as the design that I've just talked about for the adult program. And we've just finished this study too. So these are unpublished data. These are hot off the press, but I thought you might be interested in hearing about them. So we recruited 4 adolescents. We aim to recruit between 4 to 18 in terms of the age range. In actual fact, they were all kind of 14 and so many months. So they were at that much younger end of that age bracket, interestingly. That wasn't planned, it was just happenstance, it's the way it happened. Like with the adult study, we used this idea of a target uncertain situation that the young people generated themselves, that was anxiety provoking, that had an element of uncertainty to it, was something that happened very frequently, and they wanted some help to manage. And like the adult study, they completed daily diaries around this uncertain situation, and they did that for a baseline period, then during the intervention, and then for a 1-month follow-up. So exactly the same kind of design as I've already described. And similarly, they completed a range of outcome measures around uncertainty, anxiety, and worry. And we also asked parents to complete these secondary outcome measures too, at baseline, at the end of the intervention, and at the end of the follow-up. So what did we find? Well, before we talk about the results, I just wanted to share with you the types of uncertain situations that these young people identified. So they generated these situations as something that was really stressful for them and anxiety provoking that they wanted to work on. And I'm not going to read them all out to you, you can read them yourselves, but I guess one of the themes that comes across really clearly to me in reading these target situations is how much of it is underpinned by social situations. So for all 4 of them, there's an element of uncertainty related to the social world that these young people want help with. Kate also has some kind of indication of uncertainty relating to the sensory environment too, which comes across quite strongly in other data that we have. But there's a kind of real notion of kind of uncertainty related to social situations as being a real challenge for these young people. And I guess that kind of resonates back with Hannah Pickard's work that I mentioned to you earlier. So these are the data from the Uncertain Situation Daily Diaries, exactly as I explained for the adult study. And if we look at the final row there, that's the combined data across all participants. And these data relate to ratings about how confident the young people would feel in managing their uncertain situation. And we have data from baseline to the end of intervention, the end of intervention to the end of follow-up, B to C, and then baseline to the end of follow-up. And what you can see there is that there's significant changes in the way young people report confidence in managing this uncertain situation over time. So this is indicating that they feel that their confidence is growing over time in relation to that personalised uncertain situation, and that's maintained at 4-week follow-up. Of course, small numbers and very short follow-up. This is early kind of development work, but suggests some promise and some perhaps reason for continuing to explore. In terms of the secondary outcome measures, here you can see the self-report measures from the young person and also the scores from the parents. Interestingly, in relation to Kat, the first young person in that table there, she completed her follow-ups about 5 days after lockdown started. She was really keen to still do it, and so obviously that was fine. But I think, you know, and she actually said she thought the situation had influenced her reporting, and that kind of just shows, I guess, the way uncertainty can kind of interfere with our lives in kind of unavoidable ways. The picture isn't quite so clear-cut, is it, in terms of what we're seeing on the standardised measures from these young people compared to the much clearer changes we were seeing in the adult data. For Craig, his parents are reporting clinical change in response to uncertainty and anxiety at follow-up compared to baseline. That's not reflected in his scores, interestingly. And for Henry, similarly, Mum, I think it was, is reporting a clinical reduction in uncertainty related anxiety at follow-up, although again, that's not reflected in Henry's personal scores. And for Kate, we're seeing reliable change in self-report across worry, uncertainty and anxiety, but those scores are still above clinical level. So it's a bit more of a mixed bag in terms of us understanding what's going on with these standardised measures here, and we need to have a bit of a think about that, think about the appropriateness of the measures, and maybe you know, expand these data and follow up with some further research just to see what's happening here, but interesting nevertheless. So I just wanted to close then with finally telling you a little bit about an ongoing study which is also incorporating this notion of uncertainty in relation to anxiety for autistic people. And that's the Personalised Anxiety Treatment Trial, or PAT-A as it's known, which Sam Bryce is the research associate. Talked about this a little bit in his presentation in the mental health panel on Monday in relation to a clinical interview tool, addendum, that we've developed as part of this study called the PACE-A, which we're using to try and conceptualize and formulate anxiety much more accurately for the autistic adults who are participating. You can read a lot more about the PAT-A trial in the protocol paper that is indicated on the screen there. But essentially, it's kind of taking this notion of a personalised approach to treatment for autistic adults experiencing anxiety and using a bespoke an autism appropriate assessment tool to identify the pathways to anxiety for each individual participant. And on the basis of the information from the PACE-A, actually then devising an individualized bespoke treatment pathway for that individual that maps on to their personal anxiety journey. So very much moving away from this idea of one size fits all in terms of treatment, but trying to really personalize treatment pathways to meet the needs of the individuals who require support. And in terms of the the interventions that are available as part of PATE at the moment. We have a range of individual modules, if you like, of anxiety intervention that we can steer participants towards depending upon their profile, and Q's Adult is one of those. We're still in the throes of collecting follow-up data from some of the participants in the study, but we have had a look at the need for QA amongst our participants. So we have 34 autistic adults participating in the trial, all of whom have been referred from clinical services because of their experiences of anxiety. And Q's has been indicated as a primary treatment for 52% of our sample and a secondary treatment for 10%. So well over half of the autistic adults who are participating in this study have uncertainty implicated in their experiences of anxiety, and would benefit, we think, and they think, from some work on trying to manage uncertainty a little bit better. So we're hoping to be able to report on the trial by the end of this year and give you a lot more detail on that. But I just thought it was interesting for you to hear a bit about how we're taking some of this very preliminary work forward to kind of future studies. So in conclusion then, anxiety unfortunately is a very common experience for autistic people. And when it does occur, it can often be complex and not map on to kind of our traditional neurotypical conceptualizations of anxiety, and may require adapted and personalized interventions to be delivered to autistic people. Difficulties with everyday uncertainty certainly don't explain all anxiety presentations in autism, but they may contribute to the development and maintenance of anxiety for autistic people across the lifespan. And as a consequence of that, perhaps interventions that specifically target uncertainty might be appropriate, and do seem to be face valid with autistic children and autistic adults. Work indicates that they are feasible to deliver through standard NHS services, and that they're acceptable to participants, both parents, young people and autistic adults. And we have some very preliminary indicators that they may be beneficial, but of course we've got a huge way to go on that, and I very much appreciate that. We're very much at the beginning of this research cycle, but hopefully we can continue to get better at supporting autistic adults and children who are experiencing anxiety, because it's a clear priority for the community. Now, I've had the pleasure of coming to talk to you about this today, but of course this is the work of a whole army of people, not least the autistic adults, young people and their parents, who've helped us along the way, told us when we've got things wrong and advised us how to do things better. So I'm extremely grateful to them. And of course, to all the researchers, therapists, and colleagues who've contributed to this work over the past 10 years or so. And last but of course not least, to our funders over the years, the Children's Foundation, Research Autism and Autistica, and of course our NHS sponsor, Cumbria and Northumberland and Tyne-y-Wear NHS Foundation Trust. And to you, of course, also for your attention today. Thank you very much.
Thank you very much, Jacqui. So if you just unshare your screen, then we'll have a bit of a question and answer session. So just want to do a quick apology, everyone. I should have reminded you about the question and answer button at the bottom of Zoom. So if you have any questions, do submit them and get them in, because we've got a good amount of time for questions. So yeah, just let us know what your questions are. So we have some questions which have came in already. So the first one is from Julia, and she asks here, so is the idea to develop emotional regulation strategies or other strategies to enhance the tolerance of uncertainty? If children have developed other strategies, for example, avoidance, then it must be difficult to replace with those other strategies. Can you give some ideas about the sort of alternative strategies that are more focused on tolerance? So that's quite a lot.
No, that's fine. Yes, so often when families, so if we talk about the child work, I guess, in relation to Julia's question, one of the things that we did when we started working with families and parents was we asked them a bit about the sorts of strategies they were currently using to manage uncertainty, and avoidance was something that parents understandably described a lot as something that they were doing and their children were doing, avoiding uncertain situations because it was distressing, and you don't want your child to be distressed. So, you know, you may avoid putting them in those circumstances. But of course, the principle of cues suggests to us that we can't avoid all uncertainty. So we do need to build up resilience. And one of the strategies for doing that could be the development of emotion regulation strategies to help children and young people to sit in uncertain situations for a little bit longer than they may originally have been able to do. So it is about kind of developing some kind of tolerance to being in those situations before you can start to maybe challenge thoughts about uncertainty and behaviours in relation to uncertainty. So embedded within cues, there is some work around emotion regulation. There's some mindfulness strategies that we advocate some parents might want to try out. We also advocate the use of some cognitive strategies too. So challenging negative thoughts about uncertainty, providing evidence that you managed really well last week in this situation that had an element of uncertainty to it. How can we build on that? So the key thing about cues is that we provide parents with a toolbox, really, with a range of strategies that they might want to try at home with their young person. There's not one solution.
Great.
Parents pick and choose from that toolbox based upon their expertise of their child, what they think their child will be willing to give a go at, their child's interests, and also their child's age and developmental level. So we provide options and parents choose from those options.
Great, that's really, really helpful. So next question is from Alexandra, and she says it's a really great results in the CUES-2 study. Could the methods of reducing anxiety be more widely applied to other problems linked to anxiety, perhaps with cognitive components added in where necessary?
Sorry, could you say the question again?
So she's saying, could the methods of reducing anxiety that you've used, so how you've targeted something like intolerance of uncertainty in CUES-2, could those types of methods be used to address other mechanisms that cause anxiety or other issues that cause anxiety?
Sure, absolutely. So, so the methods that we're using in CUES and CUES-2 are not, it's not rocket science in a sense. It's graded exposure and support to actually tackle uncertain situations with a bit more confidence and with strategies to try and manage a response to that situation. I guess the difference with the CUES program is the fact that we're targeting uncertainty. That's the distinctiveness of it. But the actual tools and the techniques that we're supporting parents to use are very widely used tools in the anxiety literature. So things like addressing arousal, using cognitive strategies and using behavioural strategies to try and support engagement with an anxiety-provoking situation.
Great, that makes a lot of sense. Thank you. So the next question is from an anonymous attendee, and they ask whether or not you think that anxiety might work differently for autistic children who also have learning disabilities, and what do we know about that?
So sadly, we don't know as much about anxiety for autistic children who have co-occurring intellectual disability compared to those who don't. So if you look at the published literature on anxiety in autistic children, it's very much kind of biased towards children who don't have co-occurring intellectual disability. And I think there's a huge way to go in terms of understanding anxiety for young people who have an intellectual disability. Also, I think there's lots of commonalities between those who do and don't have an intellectual disability. I think the way anxiety might be expressed may be different across those two cohorts, if you like. There is emerging evidence that uncertainty is just as much of an issue for those young people with intellectual disability as it is for those without. And we do know that there's a very high prevalence of specific phobias amongst young people with autism and an intellectual disability. So there may be some important distinctions between those two groups, but actually we need much, much more work with young people, autistic young people with an intellectual disability also. And I know there's some fantastic work being carried out by Jane Waite and others at Birmingham, which is really trying to tackle that and doing a really grand job of doing that. So I'm really looking forward to hearing their findings.
Great, great. And so just everyone, just keep getting your questions in below. We'll try and get through as many of them as possible. So this is one from Amanda, and Amanda asks, in one of the Q's tables, I saw a stress scale was used for research. Was that the perceived stress scale or another measure? And if so, which one was it?
So it was the DAS. So it was the stress subscale from the DAS, the depression, anxiety, and stress scale, and we just used the stress subscale from that measure. So the DASS.
Great. Great, thank you very much. So we've got a question here from Kathy, and Kathy says, fabulous work, Jacqui, and really promising findings. Have these interventions been used with young people who are opting out of school due to anxiety and maybe other reasons, so-called school refusers? Do you think it could help in this context?
Oh, that's such an important question. And you know, it's one of the things that I'm really keen we do is try and work with schools to develop the Q's program as a kind of Q's for schools, if you like, because we've done extensive work over the years with young people and their parents around the sorts of situations, uncertain situations that are anxiety provoking for them. And time again, school comes up. It's so predictable in terms of how many times it comes up. Schools are such an uncertain place. You know, there's lots of social uncertainty. There's lots of kind of changes within the school day. There's lots and lots of uncertainty embedded in a school context. And I think absolutely we need to look at the role of schools, and we need to try and support schools to better support autistic young people and to kind of, you know, start to think about the role that uncertainty might have in a school context. So that's on my kind of to-do list as something that I really want to move towards. It's so important.
Yeah, absolutely. I totally understand. So we've got one, just looking at questions. So we just keep getting your questions in. So we've got one here about, does the Q's adult CBT include psychoeducation about the role of the nervous system and how to calm it or distance yourself from your feelings?
It does to an extent. So one of the things, so the Q's adult program is a manualized program. So therapists can deliver it kind of, you know, based on kind of a manual-based approach. But within that, just like with the Q's child program, there are options for different types of activities, discussions, and session plans that you can use depending upon the presentation of the person that you're working with. And within the manual, there is some work on fight or flight and the kind of physiological response that we might have to anxiety or to uncertain situations, and starting to kind of develop a formulation and an understanding of the interaction between our kind of physiological system and our cognitive system and our affective system. Where that seems to be appropriate for the client that you're working with, that is something that a Q's adult therapist might choose to do. So it's there in the manual as an option, as a kind of treatment plan option where it's deemed to be appropriate.
Great. And just a question for me, in terms of COVID-19 and the lockdown and the crisis that we're all going through right now, what's been your experience in terms of the needs of autistic people in respect of issues around uncertainty?
During COVID specifically?
Yeah.
Well, we haven't, I don't have any data on that. You know, we haven't specifically gone out to do some research around that. We've tried to continue with the research that we've had going, but we haven't implemented any new studies looking specifically at the impact of COVID-19, although I think it would be a really interesting thing to do. It's such an uncertain situation, isn't it, in many ways, at multiple levels, you know, so it would be surprising if it wasn't having an impact on people's mental health and on the levels of anxiety. And so I think what we may see as we hopefully move out of the current situation and into something that's more like, you know, the situation we were in pre-COVID, we might see some need for increased support around uncertainty amongst autistic people that we work with. It would be very surprising if there hadn't been an impact. I think there's been an impact for all of us, for many of us, in terms of our mental health, because of the absolute uncertainty embedded within the situation and the fact that it's, you know, fluctuating and changing on almost a daily basis. I know from the work that Renska was doing on the Q's adolescent study, she was just finishing the final participant, Kat, in that study as lockdown occurred, and you know, and she had discussions with that participant around the impact of that. She was keen to still participate in the study, but acknowledged herself that the situation was likely to be having an impact on her responses.
Thank you, that's really, really helpful. So we just got a question here from Diane, and Diane asks what your views are on medicating anxiety.
So I'm a psychologist by background. I've done no research on medication. I think there's potentially a role for medication in helping people manage their anxiety, but I think it's something that needs to be determined on an individual basis, based on a very careful formulation of that individual's difficulties, their experiences, and what the range of treatment options are. And I can really only speak from a kind of personal subjective perspective on it, I suppose, because it's not my area of research expertise. But I'm very much an advocate of personalised approaches to mental health care, and where it seems as if it's a sensible option, a sensible way forward, then I think it's something that should be considered. I think it shouldn't necessarily always be the go-to solution, and I think a range of options is the most appropriate strategy, but that's predicated on us being able to develop a range of options and have those routinely available through mental health services for autistic people to access.
Great, thank you, that's really helpful. And just another question here, how is uncertainty different from anxiety? Ask somebody. And surely all anxiety is due to uncertainty. Is that not the fundamental cause of all anxiety?
This is a really, really important question, and it's hard to disentangle some of these constructs, I guess, in a way. What we've tried to do during the course of our work is identify anxiety and anxiety situations that are very much underpinned by uncertainty or unpredictability associated with that situation. Now, of course, there will be other situations which are anxiety provoking that don't have uncertainty embedded within them, and that may require a kind of different treatment program. But for many anxiety conditions, there will be an element of uncertainty associated with it. And, you know, we've seen from the work that we've been doing in developing the personalised anxiety interview schedule addendum that Sam talked about on Monday, that uncertainty can be embedded across a range of different anxiety presentations. So I think we have a way to go to be able to kind of disentangle those two constructs successfully. But we do know that anxiety for many people is related to uncertainty, absolutely.
Great, great. So one last question, and then I'll move to the closing speech. Does physical health come up for your participants in terms of anxiety? I'm aware that sleep and food issues can come up, as can health problems around things like epilepsy and gastrointestinal issues. Are these linked to anxiety in any way?
Absolutely, and of course for autistic people and non-autistic people, health anxiety can be a real concern, and I think maybe particularly at the moment with coronavirus, and there is some research that's been done by people working in the health anxiety field, so not in autism but in health anxiety, that implicates uncertainty as an important process variable in the presentation of health anxiety. I'm not aware of a literature that's looked at health anxiety specifically for autistic people in any detail, but of course that would be an important an interesting next step. But absolutely, I think you know, on an anecdotal level, we hear about concerns and worries around health from some of the participants that we work with, but we haven't systematically explored health anxiety as a kind of condition in its own right in our work.
Great. Well, thank you very much, and thank you for answering so many questions and for a really fascinating presentation and what's such a real critical topic for people. We know that when we speak to so many autistic people and families, that anxiety and managing those issues around uncertainty are so key, and it's so exciting to see research which can hopefully help autistic people and their families to manage that. So a huge thank you for taking the time to present, Jacqui, and yeah, thank you very much. And so now I'm just going to move to the closing speech. So yes, so hi everyone, and thank you to you all for joining us. I've just realised that I actually haven't introduced myself at any point this morning, so I thought I'd better do it now. I'm the Director of Science at Autistica, and I'm very honoured to say that I'll become the next Chief Executive of Autistica on the 7th of August. And so I want to start this closing speech with an award, and this is an award that we have from Fujitsu for the use of technology in autism research. And so we're Fujitsu's charity of the year, and they've very generously sponsored this event. So a huge thank you to them for all of their incredible support. They've made it possible for us to host this event online for free, and we're really proud to have done that this year and for the last 2 years. So I look forward to continuing to work with Fujitsu and to see the progress that we've made with them. It's been very exciting, and I can't wait to see how we can work together in the future. So I'm very pleased to say, in the context of this award, that the winner of the Autistica Research Festival Award for the innovative use of technology in research, which has been generously sponsored by Fujitsu, is, let's see if I can get this up for you, Lisa Quatt at the University of Sussex. So this was for Lisa's talk on the impact of interoceptive training on anxiety in autistic adults, the aligning dimensions of interoceptive experience from the AD trial. And we thought that this study was a great example of a research project that is not only asks a research question that is of critical importance to the community, but is also extremely high quality science and uses the latest technology alongside some more traditional measures to test whether or not their intervention works. This study Lisa presented was testing if a new therapy targeting interoceptive ability, which means sensitivity to signals such as heartbeats, was more effective than a control intervention at reducing the experience of anxiety in autistic adults. And so Lisa measured this ability using the latest technology to measure the participants in the trials, heartbeats, and comparing this to their own ratings. So the evidence Lisa presented was preliminary, but it's shown potentially an exciting approach in terms of the role of interception and the cause of anxiety as well, and a potential novel way forward, which can really help autistic adults with something that's a huge community priority to them. So a huge congratulations to Lisa and her collaborators on that study on winning that award, and we'll hope to present that to her very, very soon. So well done, Lisa. I also want to say a huge thank you to all of you for joining. We've had an amazing 2,000 people sign up online, and the attendance and the engagement across all of the sessions has actually been just incredible. Thank you to all of our speakers for their fascinating talks and adapting to the online format so well. We know it can be challenging, and we're very much adapting ourselves. I also want to say thank you to everyone on social media who's been sharing the talks online and tweeting as well. And so in particular, thanks to Felicity Sedgwick, to Create UCL, and Caroline Richards, amongst many others. I also want to thank all the people who have donated to support this event, and I'm proud to say that we've had over £2,000 of voluntary donations, which is absolutely fantastic. Your support in that regard is really crucial at a time where research charities are losing 30 to 40% of their income this year. So we really, really appreciate that now more than ever. And to put on these events and to fund research and to ensure that research makes a difference, we will continue to need your support. So if you're able to donate or support us, or you just get in touch or go head to our webpage, and you can find out how to do that way. I want to also thank the team for pulling this event off, and in particular Bethan Davis, who's led the development of this event and the transition of this event from what was originally a one-day conference to a festival which now spans a whole week. If you've ever met Bethan before, you know that Bethan is one of the most impressively organised people that you'll ever meet, and she's done a wonderful job of ensuring that we bring autistic people, families and researchers together to create an outstanding programme of which showcases world-class research based on community priorities. So one of the other impressive things about Bethan, and what I'm really proud of as a whole at Autistica, is that we always want to improve. So if you do have any feedback and you have enjoyed participating, or you have enjoyed participating in this conference, please do complete the survey so we can know how to improve this event and make it even better for next year, because we're hugely proud of the festival at Autistica. We know that this festival is about the discussion of ideas and how these ideas can be used to try and improve the lives of autistic people and their families. And as a research charity, we're very much here to host these ideas and to provide a forum for respectful discussion. I'm sure, as we've promised at the start of this week, you'll have heard ideas that you like this week. You'll have heard some ideas you don't like as well. We believe that we're here to be a forum for respectful discussion, and it would be easy for us to duck contentious ideas and views at times, but we believe it's important that we create a forum for discussion around these complex issues, because by bringing people together, we believe that we can make the conversation better, and we can hopefully understand each other, understand where we agree and disagree, hopefully appreciate that we all have an overarching goal of improving autistic people's lives. And if you have missed any of that discussion, don't worry, all of the sessions have been recorded, and we're really pleased to say that we'll be putting them up online so that you can continue to watch and access this content for free. So this festival is also the last festival of our current Chief Executive, John Spires, and I and the whole team really think it's important that we take a moment to pay tribute to him. John has been with us for 5 years now, and has had a transformative impact on the charity. He's established a policy function at Autistica that has allowed us to connect evidence to real change and a focus on outcomes, and that has meant that we've been able to do things like ensure that, to help ensure that the NHS England consider autism a clinical priority, a real priority. John's founded and chaired a new coalition of 53 charities focused on neurodevelopmental conditions, so conditions like autism itself, epilepsy, learning disability, ADHD, Tourette syndrome, and many more. And by doing that, that's meant that these charities have been able to work together to understand the shared opportunities and views of 7 million people, so that we can really collaboratively improve lives and reduce duplication between charities. Our fundraising has also been transformed under John, and that has meant that we're in a position to deliver projects that we would have never been able to deliver before. So the Discover Network, critical infrastructure that bridges the gap between autistic people and research to do things like this festival, autistic-led grant schemes, the range of high impact studies that we do as well. But most of all, as someone who works at Autistica, I've seen that John has developed people and a hugely talented team at Autistica, and it's been such a pleasure to work alongside John over the last 5 years. I'm very personally thankful for the support that he's also given me. And I think one of the things that we're really proud of at Autistica is that we're a truly neurodiverse team, and that they'll work so hard and is really passionate about ensuring that we deliver meaningful change. And John, going means that, you know, and as I take on a new chief executive role myself, it means that we are entering a new era, and we will continue to be committed to improving, to learning and innovating as we have the last 5 years. We're committed to that, and we know that it's essential so that we can deliver the maximum amount of change. So as an autistic person myself, who's grown up with other autistic people and with lots of different families and autistic people, I know that we're all different, and I know that we all have different priorities and views around research. I want to really make it clear that we're committed to listening to all views, and we believe in listening to a diversity of perspectives. And I look forward to continuing to work in partnership with a range of communities, partners and researchers to deliver real change. We want to be here for everyone, and at Autistica we want to deliver change today through delivering the best information and policy work and campaigning. And we want to deliver change tomorrow through supporting and funding the best research focused on the most pressing priorities for our communities. And the reality is that the need for change, unfortunately, has never been more urgent. This pandemic is first and foremost a huge tragedy, but it also could offer an opportunity to build a better, more accepting world for autistic people. But so far that has not been the case for far too many autistic people. It's my view that we cannot accept a world where autistic people are marginalised, where basic rights that most people take for granted are just seen as nice to have by too many, and something that can be deprioritised in times of crisis. Autistic people should have an equal right to exist, a right to be who we want to be, to express our own wishes, to have a right to work if that's what they want to do, a right to healthcare, to evidence-based social care, to treatments and support for anxiety and other mental health issues, and to live in a world that accepts and accommodates autistic people and all forms of neurodiversity. This shouldn't be controversial that autistic people and their families have been asked to wait for too long, and these are rights which we must grant all autistic people. And so, in our efforts to increase the pace of change at Autistica, we will be changing again. Next week we will have a new look and a new commitment to make more of a difference, to reflect the diversity of autism and to ensure that we as an organisation are greater than the sum of our parts in the impact that we have. A huge part of that for me in my time as Chief Executive will be campaigning for more funds so that we can deliver real change. And that's why next week we'll be saying it's time to know more about autism. We'll be unapologetically campaigning for research which will ensure autistic people get access to the rights that they deserve, and fundamentally to ensure that all autistic people have the right to live a long, healthy, happy life. Your support, as ever, will be crucial as we do that. So, all that's left for me to do now is to close this conference and say a huge thank you to all of you again for joining us and for your incredible support. I hope you have a great Friday and a relaxing weekend. And goodbye, and I hope to see you all soon.